Okay, well, hello everybody. My name is Faye Burrows. I'm a heart and lung transplant pharmacist from right here in Sydney, Australia. And welcome to this ISHLT 2027 abstract submission webinar on best practices. So I'll just give you a brief outline of the plan for this webinar. So after my brief welcome, Melissa Casino, who is the ISHLT 2027 Scientific Program Chair, is going to provide an overview of the 2027 meeting and some abstract submission considerations. I will then run over some key considerations and the role of the Program Planning Committee. And then we have Tomoko Kato, who is going to provide us with some tips on some common pitfalls in abstract submission. And then John Kabashigawa will give us some advice on what's going to make a really great abstract. And then at the end, we'll have plenty of time for discussion and a question and answer session. So please keep your questions to the end. All right, so I'd like to hand over to Melissa.
Thank you, Faye, and welcome everyone, both those of you joining us live and those who will be watching this recording back. And many thanks to our ISHLT team, as well as all of our speakers, who I know are going to be providing us with such rich information, tips and tricks for the next phase of abstract submission. On behalf of our ISHLT Scientific Program Planning Committee, I just want to share how excited we are to see your science, to receive your abstracts. This meeting, ISHLT 2027 in Sydney, Australia, is truly a historic one for our society. The first time that we will be visiting the Southern Hemisphere, the first time that we will be in Australia. And we, as a scientific program committee, are already just really overwhelmed by the engagement of our community in this meeting thus far. We had a record-breaking number of symposia submissions. We had first-time submissions from a number of countries across Asia, and we saw growing submissions from our colleagues in Australia. And we are really hoping to see that trend continue with abstract submissions as well. So just really grateful that we're putting together this webinar and sharing this information with all of you, and really excited about your interest. To tell you a little bit about the meeting that we're crafting, we are building a meeting that is really motivated by three themes. I think three themes that are key to ISHLT and our membership. The first is purpose, our purpose in our work, our purpose in our science, our purpose in our coming together as team members and as an ISHLT community. The second is built on teamwork, our teams in our clinical work, our teams in our science and in our labs. And the last is innovation. So the innovation, of course, is what this meeting is known for, and why we hope to see you all in Sydney. And so on behalf of our entire scientific program committee, thanks so much for tuning in, and we really look forward to seeing you in Sydney.
Hey, you're muted.
I'm sorry, forgot to unmute. So some key dates. Abstract submission opens on Monday, the 3rd of August, and the submission deadline is at 29th of September at 11:59 p.m. Eastern Time in the USA. Those abstracts will then undergo review by the abstract reviewers in a 2-week window between the 7th of October and the 20th of October, with the abstract selection by the Programme Planning Committee happening between the 26th of October and the 20th of November. You will hear if your abstract has been accepted on the 4th of December, and then presentation invitations, where you will find out whether it's an oral or a poster, will be on the 18th of December. And the deadline for confirming or withdrawing is on the 22nd of January. So you've got a bit of time to try and organise your travel plans. So these deadline dates are a little bit earlier this year, and that's to allow attendees to have that extra time to make travel plans to travel to Sydney. So some exciting updates for this year. For ISHLT 2027 only, the organisers recognise that for many people it's a big ask to come to Sydney. So there will be an option for an electronic poster submission if you know in advance that you will definitely be unable to attend. And also this year, case reports will now be open to all submitters, regardless of your career stage. So previously, the case reports were limited only to early career professionals and trainees. And now we've opened that up for submissions from anyone at any stage of your career. The early career professionals and trainees will continue to be eligible for the Early Career Awards, which will recognise the very best abstracts in that category. So a little bit more about the e-posters. So for this year, we have the e-poster submission options. So if you are certain that no one in your team is going to be able to travel to Sydney, then you have the option of the e-poster submission or case report submission. Those accepted e-posters will be published as part of the abstract supplement in the Journal of Heart and Lung Transplantation and will be displayed electronically during the meeting and available to registered attendees. If you are accepted as an e-poster abstract, then you will not be required to present your work either in person or virtually, and you will not need to register for the meeting. But if you think that either you or a member of your team and someone from your team can present multiple abstracts on your team's behalf, then please do consider putting it in for a full submission and have the opportunity as a full poster or oral presentation. So a few more key considerations. The limits for characters for your abstract submission. It's a character limit, not a word limit, and it will include the title, introduction, abstract body, summary, and include headings. And that character limit is 2,140. If you want to add a table or an image, that will reduce your number of characters that you can have in your abstract by 320 characters. So you need to think carefully about whether it's the best way to present your data is to add that table or image, or whether you can use that extra character limit to add more to your abstract body. Very excitingly, ISHLT has doubled the amount of travel grants that will be available for the ISHLT 2027 meeting. So keep a lookout for more notifications about that and how you can sign up. There will be more detailed guidance on how to submit your abstract on the website, which will also include the submission categories. So think carefully about where you want to submit your work. You will use your ISHLT login to log into the submission site. So you don't have to be an ISHLT member to submit. You just need to create a login for the ISHLT website. Abstracts will then go through comprehensive blinded review process, so the reviewers will not know your name, your centre, which country you've come from. And then after we get the scores for the abstract reviews, the programme planning committee will then make decisions about where that abstract slots in, either as an oral or a poster. So this year there will be 5 types of submission, 5 options for submission. So there will be research abstracts for clinical research, studies, etc. There's also the option of a late-breaking abstract. That's for studies that will not have results ready by the September abstract submission deadline. As we've said, the clinical case reports are now open for all submitters. And then you have the option of the e-poster submission or the e-poster clinical case report submission. So this is the rubric that the abstract reviewers will be using to score the abstracts that are submitted. So as you can see, the very best scoring abstracts will be world-leading research, highly innovative, very high impact, and likely to be published in a top-tier journal. What the reviewers are looking for is relevance to the society and to the audience, that it's well designed, is innovative, and it's likely to have some sort of change in impact. Those will be the studies that will get the best reviewing score. And the rubric for the case presentations will be slightly different, obviously. So a little bit more about the late-breaking clinical science. So these submissions is an exciting opportunity to share cutting-edge, high-impact research. They typically feature prospective randomized trials with innovative approaches to diagnosing or treating cardiothoracic disease. So the goal of this is to highlight work that's really important to share with the community as soon as those results become available. So it's for those studies where you will definitely know that you will not have results and conclusions available by that 29th of September abstract deadline. If you do have results and conclusions ready by that 29th of September, it would not be considered late-breaking science, and it would be should be submitted as a standard research abstract. So those late-breaking abstracts will be submitted as a placeholder, and then the final abstract will be presented at ISHLT 2027. So thank you, and I'd now like to hand over to Tomoko Kato. Tomoko.
Okay, so, well, good morning or good afternoon, everyone. My name is Tomoko Sugiyama Kato from Japan. I have been involved with ISHLT for more than 25 years as a member from Asia. Today, I would like to share a 5-minute message about common pitfalls in abstract submission. And most importantly, hope this short talk will encourage many more colleagues from the APAC region to submit their work to ISHLT. Well, so ISHLT has a long history in Asia. Many of you may remember the ISHLT meeting in Osaka in 2000. I was actually pregnant at the time, and my daughter is now 26 years old. Time really flies. You may recognize Dr. Sharon Hunt and Dr. Norman Shumway in these photos with me, two pioneers in heart transplantation. Now, now we have another opportunity to gather in APAC as we look ahead to Sydney 2027. It has been a long time since ISHLT was held in APAC. I hope we can make Sydney 2027 a memorable meeting by bringing many more voices from APAC to the ISHLT stage. Next slide, please. The purpose of this talk is simple. We want more abstract and more voices from Asia. Asia is still underrepresented at ISHLT, even though our work has a lot to offer the international community. Too many excellent studies never leave the desk because of hesitation. So today, I'd like to share 5 common pitfalls and how to avoid them. Next slide. These are the general pitfalls in abstract submission. They apply to everyone and are already well covered in the ISHLT guidance. So today, I'd like to focus on 5 APAC-specific pitfalls. Next slide. Well, pitfall number 1. Your Asian experience is the story. Frame it that way. We often read phrases like, "We are a small center," or "This is our local experience." Don't apologize for your settings in the abstract. That is not necessarily a limitation. It may be the scientific message. Your setting is not a weakness. It is part of your story. Next slide, please. Okay, so pitfall number 2. Give the reviewer one clear take-home. The trap is trying to say too much. If reviewers remember one clear take-home, your abstract has done its job. Next slide. So pitfall number 3, tell the international community why now and why APAC experience matters. Don't just describe what happened in your community. Make the message global. Give reviewers a clear hook, a new therapy, a new controversy, an APAC perspective, or an unmet need. Next one. Okay, pitfall number 4. Focus your story. One study, one question. Sometimes we see 3 objectives, 5 endpoints, and 1 confused reviewer. A focused message from APEC is stronger than a broad story. Save the rest for your next abstract. Next slide. Okay, so finally, the biggest pitfall. Please don't reject your own abstract. Before submitting, you may think, my center is too small, my English is not good enough, our experience is too local, we don't have famous collaborators. None of these disqualify you. The only abstract that can never be accepted is the one you never submit. We hope to see many more abstracts from APEC this year. Next slide, please. So this is the final message. The ISHLT program needs your voice. If your abstract speaks to a real clinical program, shares a lesson others can use or learn, and it didn't clearly, just submit it. We hope to see you all in Sydney. Thank you very much.
Thank you so much, Tomoko. And now John Kabashigawa will take over and tell us what makes a great abstract. John.
Thank you so much, Faye, and welcome everyone. Good morning, good afternoon, good evening, wherever you may be. I'm John Kabashigawa from Los Angeles, and thank you, Tomoko, for reminding me about the 2000 Osaka meetings. I was actually the program chair at that point in time. I guess you could do the math as how long I've been a member of the ISHLT. So my charge has been what makes a good abstract, and there was my disclosures. I'm going to take this a little bit more into the weeds in terms of content, in terms of what can we talk about in terms of putting together a great abstract. First of all, research idea from working in the trenches. I think you all know that if you take care of patients, you will see what the unmet needs are. Formulate a plan to address the question and do your homework as to previous studies on your project. And you'll see that there are many areas that do not have enough data. Gather the data to answer the question and to analyze it, and then tell a complete scientific story, a clear purpose, sound methods, meaningful results, and evidence-based conclusions. Next slide. Now, we all know that we're very busy in what we do, and so there is this practical conundrum that we all have. Busy clinical responsibilities, meeting billing expectations, administrative time, little or lack of protected research time, and there's always that issue of funding of some of these studies as well. Next slide. So there are some keys to clinical research. Clinical experience, keep your eyes and ears open while working in the trenches of patient care. What are the unmet patient needs? Ask the right question. Challenge dogma. We don't always have to say that, we're going to treat with 1 gram of salmeterol for rejection. And in fact, we now know that we can give much less to treat rejection with an oral prednisone bolus and taper. And that was one of the first clinical trials that I'd actually put together. Now think about a possible study. Do the literature search, organize the study, and then, of course, what data is needed. Next slide. Well, let's get down to some clinical study examples while in the trenches of providing patient care. Back in the 1990s, cardiac rehabilitation was paid for by Medicare following open heart surgery, myocardial infarction, even coronary angioplasty at that time. Our heart transplant patients were not approved for cardiac rehab by Medicare. And when asked why, this was the reason. There have been no studies demonstrating benefit. So we did a study. Next slide. We randomized 27 heart transplant patients, 2 weeks postoperative, randomized to 6 months of structured cardiac rehab or unstructured home therapy. In other words, patients were just told by the physical therapy on how to exercise and how to do stretching as well. We did cardiopulmonary stress testing performed at baseline and repeated it 6 months later. These were the results. Next slide, please. No surprise, the yellow represents the exercise group and the red represents the control group. There was significant improvement in peak oxygen consumption, workload, exercise time, and sit to stand, a measure of strength in the exercise group. Next slide. So we concluded that structured cardiac rehab appears to be beneficial in attaining a greater exercise capacity after heart transplantation. And now remember, we randomized 27 patients on a slide. And where did we actually publish this? We published this in the New England Journal of Medicine. Well, let me go on to another example. And that's hyperlipidemia is common after heart transplant, seen in 74% of patients at 1 year post-transplant. The impact of cholesterol lowering was not established in early 1990s, which was prior to the first multi-center statin studies, the 4S studies that were published in 1994. And that's a simvastatin survival study. At this time, statins was associated with myositis and even rhabdomyolysis in solid organ transplant patients due to the drug-drug interactions with cyclosporin at that time. Now, pravastatin is hydrophilic and believed to have less myositis, and so we decided to do a study using pravastatin. Next slide. So we randomized 97 patients to pravastatin, 47 patients, or no pravastatin, 50 patients, beginning way back in 1989. The primary endpoints at 1 year included cholesterol levels, rejection, survival, transplant coronary artery disease by coronary angiography, and first-year intravascular ultrasound, otherwise known as IVUS. Next slide. And here are the results. The average cholesterol level, no surprise, we decreased that with pravastatin, 193 to 248 in the control group. What we did not expect was that we actually knocked down severe rejection. Pravastatin group, 3 patients, control group, 14. And this translated to a survival benefit in the pravastatin group, 94% 1 year survival, 78% in the control. And at that time in the 1990s, what was 1 year survival is about 80%. So the control group was pretty much right on. The transplant coronary artery disease by angiography or autopsy, 3 in the pravastatin group, 10 in the control group, which was also significant. Now, we also had done intravascular ultrasound, looking at intimal thickening, and yes, we had knocked that down by 50%. So the big question was, why is this happening? Why is a statin lowering rejection episodes? So I said to my fellow, Steve, would you take a look at literature search and see if this has any statins have anything to do with immunosuppression? Well, he comes running back to me and says, look, I found a great study by Dr. Lynn Cutts and colleagues from the University of New Mexico that statins can knock out natural killer cell activity by as much as 98%. So we did a study. We went back to the bench and we looked at natural killer cell cytotoxicity. We found that that pravastatin knocked it down to 9.8%. In the control group, it was 22.2%. And what is it for everybody else who's not a transplant patient? It's about 28%. So certainly immunosuppression does lower it, but by adding pravastatin, we lowered it even more so. Next slide, please. So the conclusion was, after cardiac transplantation, pravastatin had beneficial effects on cholesterol levels, incidence of rejection causing hemodynamic compromise, 1 year survival, and the incidence of coronary vasculopathy. And just about 2 years later, it was published by the German group that simvastatin had the same exact results. Now, there's been more studies, as you can see on this slide, the anti-inflammatory and/or immunomodulatory properties of statins. Yes, it can suppress T cell responses. It can reduce expression of MHC class II on antigen-presenting cells due to the suppression of the class II transactivator promoter gene. Reduces chemokine synthesis of peripheral blood monocyte cells and can block lymphocyte function antigen 1 to decrease lymphocyte adhesion to intracellular adhesion molecule 1 and impair T cell co-stimulation. So a lot of things that statin can actually do. Final slide. So in summary, while in the trenches of patient care, keep your eyes and ears open to glean unmet needs. Ask a relevant clinical question, and the results either way will be meaningful. If it's negative, that's good. Something we won't be doing for our patients. If it's positive, something that may be helpful. Now do your homework and literature searches, data collection, and stay organized. And keep questioning why is observed happening, question dogma. And with that, from sunny Southern California, next slide. Thank you so much.
Thank you, John. That was excellent. Thank you for your insights. So I'd just like now to put a shout out to encourage everyone to apply to be an ISHLT 2027 abstract reviewer. This is such an excellent opportunity to start being involved in the ISHLT. You do need to be an ISHLT member, and you will be requested to review up to 60 abstracts. You get to choose which categories of abstracts you would like to review. It's a really great way to learn more about the research that is happening in your clinical area, and it looks really great on your CV as well. So you need to have reliable internet access and be available for that 2-week period between 7th of October, 20th of October to review those abstracts which will be assigned to you. But please do sign up. The link is on the ISHLT website. And with that, I'd like to thank you for attending or listening to this webinar, and thank you for everything you do to help shape what will be an amazing meeting, ISHLT 2027. This roadmap to Sydney is available on the ISHLT website with all the key dates for preparing yourself for the meeting in Sydney. And with that, I'd like to open it up for questions. You can put them, I think, in the chat at the bottom, or I'm not sure if you can unmute.
So one question that came in is, will we need to present if we are doing an e-poster?
So there is absolutely no need to present either in person or virtually for the e-poster. The e-poster will be displayed at the meeting, but you will not need to attend or be available to present virtually.
I'm looking for the abstract topic list. Where will that be available for review?
So the abstract topic list is available on the ISHLT website. So if you go to the annual meeting, you'll be able to follow the links to the abstracts topics lists.
Should I reach out to a member of the program planning committee with my ideas before I submit?
So the program planning committee are unable to comment on individual abstracts to make sure that they have that confidentiality and no conflict of interest when they come to review and put the program planning committee. But I would definitely encourage you to maybe get someone senior in your department. Definitely helps to have someone else to review your abstract before you submit it, just to make sure that your science is making sense. I don't know if Tomiko has any more comments, or John, if you'd like to add to anything to that.
Well, thank you, Faye. I think it is important to have input from your senior person in your group, mainly to give some ideas about relevance of your study and what really makes what makes an impact. Now, I might just add something, maybe a little bit humorous here, though, too, is that sometimes it makes sense to have a really catchy title to this. We did a study on ICDs in patients with severe, CAV. So the title of this was the Shocking Truth, the Benefit of a ICD in Severe CAV. So sometimes, some catchy titles may get the attention of your reviewers. I don't mean to be too humorous about this, but again, I think there are ways to do this.
I agree. I like a good catchy title.
And if each of the panel members could just give their best piece of advice for someone submitting an abstract for the first time to ISHLT 2027.
Who'd like to go first?
Yeah.
Yeah, please.
So some first time. So actually, I remember when I when I submitted my abstract first time. So it was from the Stanford, but my English was not actually. I don't have any confidence, but I just write it, and then so my bosses show hand, and then Hannah Valentine reviewed it, and then I brushed it up. And then so anyway, so first try, and then so during the process, I can learn a lot. So actually, so if you have any questions, and then so if you don't have answer, it's okay. So just to start writing, and then I think your colleagues or your bosses would definitely help you. So anyway, so to start would be the most important issue, I think.
Well, thank you, Tomoka. Let me chime in on that. I have actually a introduction to research summer internship program where I have young medical students and even residents come in to do clinical studies for the first time. And basically, what's important is for them to understand what science is about, in terms of how to put an abstract together, what data you're looking for, and actually come up with some hypotheses in terms of what your abstracts might show. So you have at least a direction as to where to go on that. So once you do put you get your data and your mentors help you to put together an abstract. What really is important is for you to do your homework, as I mentioned before, really know what's been going on in the past, but also to practice. Practice, practice, practice makes really a great presentation as well. And not only that, when we have our practice, we have practice sessions in front of my colleagues so that we can basically ask the same questions you might get as reviewer or as a moderator in terms of whether it's an oral, whether it's a poster presentation, and even how to present a poster. It's not that easy in a sense. You don't really want to just read everything on the poster, but you want to more or less summarize, your ideas in terms of the poster. Get right to the results quickly, so you can go over that and then get down to your conclusions. These people will have read your poster for the most part before, they come to you because they're interested in the work that you've done. So the fact that the more that you are, prepared, the area, the literature search, and you'll do very well. And I'll tell you a little bit, a cute story as well, because I think this is pretty funny. One of my, my young ones, fellows, was presenting a paper, and this gentleman comes by. His name tag is turned around, so he couldn't see his name. And so my fellow starts talking about this topic and says, this topic was really done by Dr. Mira et al. And really showed that this was a result of the study. And so afterwards, this person said, yes, it was a great study indeed. And then my fellow said, by the way, what is your name? Your name tag is turned around. He turns his name tag around and says, I am Mira et al. So it was Mandeep Mira. So this was quite funny. But the fact that he had done his homework, he actually mentioned Dr. Mira, it brought much joy to him, to say the least. So anyway, just some things you'll see as you present cases, your studies. You'll be amazed, and you'll be asked questions by people you have read about, their names, and you'll find that they are very supportive. You'll find that they're pretty much in your court, and they'll be very happy. And maybe, just maybe, you'll hook up later on as well. Stop there.
Thank you so much, John. That was excellent. So I suppose my tip would be to think carefully about which submission category you're going to put your abstract into, because that will then dictate which type of professional will review your work. So if, for example, as a pharmacist, if I put my abstract into a session, into a category that involves therapeutics, I will be expecting that some pharmacists will be part of that reviewing group, so that you want people to review your work that are across the science in that area. So that would be my final tip for this. And if no one has any other questions or any other comments, we might wrap things up. So thank you very much for joining this webinar. The recording will be available on YouTube for future reference. So the links will be sent around shortly. And I'd like to thank our panelists very much for their insights and contributions to this webinar, and thank the ISHLT staff for hosting this for us. So thank you very much, and looking forward to seeing you all in Sydney in 2027.
Bye-bye, everybody.